Okay, now recording is on. Okay, so hopefully you can hear me. I'm starting with the very first slide, January test. I'm Dr. Mamun. Full name is Manol Mamun. You can call me Mamun, is okay for me. Okay. So we'll first introduce the basis format 2023. Since 2023, Royal Colleges completely changed their format, and it's very important to understand with which station you are starting in the real exam. Okay. So then you can take some mental preparations, okay, with a station in the upcoming, okay, just after this year's station, then it will help you because this is very important to preset your mind first. For example, if you're starting with cardio and neuro, you have to be very uh, attentive and serious in that sense that you have to encounter two clinical stations in a row. Okay, you will not get any times. So you have to prefix yourself, then you should move on. But when someone is starting with station one, where the respiratory station along with some communication, this I would say is very relaxing stations. You will get time, you will start with the communications, okay, then gradually pace up to the clinical station. So this is actually a good stations according to my experience, as well as the station code, where you will encounter abdomen, then a communication station. So these are the two stations. It's very lucky those are who can start with this. And consultation is also a good station to start with, but in the consultation, lots of things you have to cover. So sometimes candidate feel shaky. I got some experience from different candidate. When they start with long clinical station, they feel shaky because you are entering the exam hall with the first case. You don't know what is actually waiting for you. So yeah, it's natural to feel in that way. So that's why it's very important to prefix the mind. This is the new format, although the picture is a little bit blurred. Okay, hopefully you can see it. In this station one, communication station and respiratory station. Okay, then you will get 5 minutes interval in every station. Before starting every station, you will get 5 minutes interval. And please, during this 5 minutes interval, it's very important what you are thinking, what you are actually noted down. This is very important. Forget about your past station. What is gone is gone. You need you should not think about the past, previous station. It will impact your upcoming stations. Okay, in the 5 minutes, if you are ready for the communication station, I will recommend read 3 times. Read the complete communication scenario at least 3. The first one will be slow, a little bit slow, thorough, one by one, word by one. The second one will be the underlighted point. What are the key points? Okay. And after reading the first read, you should immediately note 3 or 4 things. Okay. First of all, what's your role? Write the complete role, not just you are a doctor. No, you are a doctor in the general medical. Uh, just in Dr. Deepan Prabhakar. Okay, so your role should be complete. You are a doctor in the chest clinic or general medical ward. Exactly, write it down because the British examiner noticed it. They notice it very well how you actually attentive and careful about these tiny things. Okay. Sometimes in most of the cases, candidates say, I'm one of the doctors in this clinic. No, I'm one of the doctors in this general medical clinic. You have to be exact and accurate. Number 2 things, name of the patients, full name, Miss or Mrs. with surname, as well as also full names. For example, Mr. Andrew Jackson, 28 years old. Write it down clearly, okay? Because you had to call the patients by name and how they want to be addressed. It's very important. Third things, if the surrogate is going to be his daughter or relatives, or it could be father, mother, anyone, write it down. What type of relatives they are. Is their wife, son, daughter? Everything is important. Then, very important things, you should go to the bottom line, read your task. What is the task that they want to perform? Write it down very clearly. Try to understand what they mean by that. I always say there are two types of tasks in communication. One is visible, another is hidden. So first, your task is what is written here. Try to understand, note it down, take some notes for plan, what we are going to tell to the surrogate. As well as try to see, is there any hidden agenda is there? Any hidden task is there? What can I do more? Although it is not written in the scenario, but I have to cover. For example, in a palliative scenario, you have to address few things, although it was not written in the scenario. This is living wish, lasting power of attorney, advance directives, palliative care, okay, as well as also if the patient is just going to die or impending die within days or hours, how he or she expressed his wish to be spend the last hour. Everything matters. Okay, even you have to arrange some pursue religious leader, you have to offer it. So these are the very important, the task part. Now, in the third reading, you should read the scenario once again. This is your last, and you have to these things. I mean, 3 readings with notes within 3.5 minutes. What are the purpose of next 1 minute? Because you will not get 5 minutes as a whole. You will get 4 minutes 30 seconds, because you have to move from one station to another station, one room to another room. So be predetermined. You are not going to get 5 minutes completely. You will get 4 minutes 20 seconds, 5 minutes. So for the last 1 minute, your task will be rehearsal. What you are going to, according to your written plan. This is very important. If you just imagine what you are going to say, it will improve your performance at least 15%, 20%. Because you are ready for that, or what is going to come or encounter. So that's my important tips. Any point, any questions at any times, please feel free to ask. No worries. I'm continuously telling, if you have any questions, queries, anything, feel free to ask anytime during my slide presentation. Or they want ask from us, okay, what they want from us, okay, understanding marking system is a very key to pass your exam. So what exactly you have to know that. And to be honest, from my experience and basic journey, when I practice with my different colleagues, partners, they even don't see the marking system. And in most of the cases, it happens because we don't know what they actually wanting from us. If you know the game, even with the little knowledge, I would say, to be honest, I see many candidates with just little knowledge, they pass because they know the game. They know how the marking system works. And I will show you one by one. Because I in these sessions, in this course, not I am just going to give you a lots of scenario and you practice. No, you have to understand the marking system. And according to the marking system, your performance will increase up to 5 or 10%. Because when you will know, okay, I have to seek the questions, I have to seek the concern. Okay, if any concern is coming, I have to stop there and answer his or her concern. Okay. So first slide, okay. Can anyone say which station mark sheet it is. Just be interactive. Try to make it fun.
Communication.
How many skills there here? 1, 2, 3, 4,
Five skill.
5.
Sure,
So
sure.
in every skill there are 4 marks. So it is 5. I mean, there is 20 marks here. So it is clinical stations. Okay. In the
Showcases.
communication station, usually 4 skill. There is no clinical examination. There is no clinical sign. Why? There is judgment, concern, patient welfare, and communication will be added, right? So just look at the first part skills of the clinical station. Physical examination is very important. What we understand, okay, you have to just do the examination. No, they observe everything. How confident you are, how fluent you are, how your micro movements during handling the patients. Believe me or not, I feel and I pass, I saw in my own eyes, even you make some mistakes, but your presentation, your handling with the patient is very gentle, very professional. They will mark you and they will give full marks. Okay, I will share a few things after just discussing this slide. Then you will understand why is that pitfall and what is very important. The physical examinations is not about the technique, how you are palpating, discussing percussions or auscultations. Okay, this technique should be arranged, should follow chronological order. Okay, and you're handling with the patients, for example, rolling up, right, left. I'm going to touch. Everything matters. Believe me, everything matters. It's not about just doing examination. It's all about a gentleman approach with the patients. Okay. If you look at the satisfactory bar, I mean column, there are 3 words. We hardly follow this. Correct, thorough, systemic, and fluent. If you miss any of this component, they will cut the marks and they will give 3 out of 4, 2 out of 4. And one single marks can cause significant damage. You know that. You probably heard from different colleagues, they fail from just for 1 marks. So I would say be accurate, correct, thorough, systemic, and fluent. On contrast, if you look at unsatisfactory, why? Despite of doing everything, some candidates are, getting unsatisfactory. Incorrect technique. The technique is not sound. Okay, it's not good. Okay, thorough clothing. If you examine over the clothing, you will get. They will give you the 0 immediately, and it will not impact your first skill. They are assuming that you are not professional. They will give you the less marks in the rest of the skill. Okay, so first impression is very important. And yes, it actually works. First impression is the last impression. If you make some mistakes in the other skill, still they will give 4 marks. Okay, so what are the unsatisfactory, reason of unsatisfactory? Omit important parts that we all usually know that. Unsystemic, not following the chronological order which is supposed to be. Hesitant, not flat. Although you are following all the chronological order, doing everything, but you are not fluent, they will cut the marks because they will guess you did not practice enough case in the bedside. So everything matters. Confident. We sometimes underestimate this skill, but believe me, this is important. The way you handle, the way we talk, and the way you examine the patients and touch the patients, everything represent yourself. How fluent, how professional you are. Okay, now the second, identifying the physical findings. You know that it's very simple. If you find the character, they will give the satisfactory. If you not, they will cut the marks. But more grievous mistakes or pitfall if you make the wrong one as during your presentation, which is not there. You should not. If you have some confusion, keep it hide. If they seek for, Is there any findings? Then you can think, yes, probably what I'm guessing, they're asking for that. Then you can think there might be in soft voice. Take some risks in that situation is worth. When you know that you present everything, but they're saying, is there anything else? In that case, you can put some, yes, there might be. Because you already know that you missed something, they are going to and ready for cutting your marks, but you have something in your mind, better to tell and take the risk. Because when you take the calculated risks in the paces, you will win. You will win. Okay. So in the third scale, differential diagnosis, many candidates failed in this skill. Differential diagnosis is very easy in that sense. If you, preset before the exam during your preparation. For example, in the cardiac case, what is the differential diagnosis of aortic stenosis? It should be aortic sclerosis, ASOCM, and if you want to tell the third one, PS could be, but not necessarily you have to mention it in the real exam because they are satisfied with two. Okay, so it's very important in all stations, especially for clinical station, along with 2 clinical consultation. Okay, so good constructive as well as sensible differential, it means when you are saying something, you have to justify that this, for this reason, I said that this is my differential. If you can justify your differential with number of findings, I got this patient, you will get the marks. Even the scenario, even you are prefixed, okay? For example, this is one of the cases, diabetes mellitus, along with some postural drop. Patient has diabetic dermopathy, also some hyperpigmentation, okay? So in that case, you can think about, okay, patient has type 1 diabetes along with some hyperpigmentation. So why not? It could be a case of autoimmune polyglandular syndrome. Although the patient has, diabetic dermopathy followed by development of some pigmentation. But if you put this diagnosis, yes, it could be. Why, if doctor asks, why you are thinking that? Sir, I got patient has diabetes along with some pigmentation, probably due to Addison. Doctor, why? Did you find anything else in favor of Addison? Yes, sir. I got some postural hypertension. Although patient has postural hypertension due to what? Due to autonomic neuropathy. So if you can put logical, rational, justifiable reason, they are bound to take it. That's my suggestion. Okay. So now going to what are the pitfalls that can lead us unsatisfactory? Poor differential diagnosis that cannot you connect, that cannot you correlate. If they ask, okay, why you are thinking, doctor, this is your differential. If you cannot justify with two, at least 2 or 3, you should not mention. You should not mention. Okay. The clinical judgment, very important. It's actually, in my opinion, this is one of the most important skill as a physician. It will not only important to pass the exam, it's very important to take clinical decision in our daily practice. It means how rational you are, how I am thinking, what could be the diagnosis, and based on the diagnosis, what could be the management. This is very important. Okay. So if you hit the wrong diagnosis, ultimately it's going to affect your subsequent scale. So it's very important to get the diagnosis at least within the differential. Then it will help you to carry some marks from the clinical judgment. Now, explore what is clinical judgment. What do we mean by that? In our conventional practice and our different mentor teach us, okay, say just management plan. It's not about just management plan. If you read the judgment part very carefully, there are some hidden information there. Appropriate and accurate clinical knowledge to determine a sensible and relevant management. It should be sensible, It should be relevant. It should be to the point, including a time scale. Another myth is going all over the mentorships levels in our country as well as also overseas. Don't mention time frame. No, if you are confident enough, okay, you should stop the driving for 4 weeks. You should mention. You should mention if you are confident enough. Doctor, I have erythemaneurosis, and you say that's going to be self-limiting. Okay, how many it takes? As you know, it's going to be resolved within 6 to 8 weeks. You can mention. So if you can mention, it will give you another impressions to the examiner that you are a very good, knowledgeable candidate. If you can, fine. If number is difficult for you, you can skip that. But my information, my suggestion, please, not always. Those are the common time frame, time scale you can remember, you can memorize, you can put in front of your desk, see everything every day. It will actually be a muscle memory for you. It's not a big deal at all. Okay, so relevant management plan, including time scale for a specific clinical scenario. So when when candidate is saying, I mean, patient is saying, doctor, I have a CAVG operation, you know that, when I can go back to home. And you know, usually CAVG patients are discharged after 7 or 8 days. They can return back to their normal life after 3 weeks. So if you know that, say it. It will carry the marks because, you know, most of the examiner don't memorize the time scale. They will memorize how your lip is talking. If your mouth is talking in a confident way, they will accept it and they will assume you're right. Because, you know, it's very difficult for them as well to remember all the time scale. Are you following me? Any questions so far? So unsatisfactory. In the unsatisfactory part, fails to apply appropriate and accurate clinical knowledge. This is very important. I mean, management and how you're thinking. Incomplete and incorrect management. Incomplete means, for example, patient presented with hypotension due to hemoptysis or melanoma. Okay, patient probably in shock. You're just giving fluid, okay, as well as also IV blood. You are not planning for, okay, what is the source of bleeding, how we can prevent it in future. Probably patient has very serious bleeding. So this is incomplete. You have to mention the immediate as well as what's the long-term plan. And as a physician, this is the complete view, and complete view should be, everybody should be encrypted. Okay, that will I mean, keep you on the satisfactory part. Then in criteria, okay, fine. I said that. Managing patient welfare. And it's very easy skill to get full marks. I already said that 5 minutes ago. I will share a story with you from my examination experience. Okay. Patient welfare is nothing about just seeking concern as well as also maintaining privacy. Clothing took off as well as also took over after and before and after the examination. At the same time, how much you are empathetic or intonated with your patients during the giving comment. If you said, can you remove your shirt? No, it's the harsh voice. Be soft, warm. Okay. This also because, you know, if patient get emotionally hurted, if you look at the unsatisfactory part, physical or emotional discomfort. Did you get my point? So we all know about just physical part. Okay, if we give the pain, examiner will cut my marks. No, they may not cut your marks. Be attentive with your emotional voice. Okay, how you want to be perceived from other. Okay, how you want to be treated from other. If you say, for example, Mrs. Helena, I'm going to examine your legs. Okay, do you have any pain? During my examination, if I cause pain, let me know. I'll be gentle enough and I will stop immediately. If you take these permissions, if you take this permission, even in the middle of the exam, you give some pain or patient feels some pain, you already have some, tool or weapon. Well, you already took the permissions. And what exactly happened in my case? In my case, when I was giving the last station, my last station was cardio and neuro. In the cardiology stations, there was a 65 years female patient, which was just sitting there in the Indian center. There was a stocking in her legs. Okay, so when I want to check the legs, examiner said there is no need during the inspection because patient has clubbing. So I would like to see the grade 2 or other 2. Is there any clubbing presence or not? Examiner said there is no need. I started with the gentle permission, rubbing my hands, then with the alcohol solution, then start the examinations. And the later part and the finishing part, I would like to check your ankles. Okay, do you have any pain? Examiner said, no, there is no pain. You can proceed because the surrogate, patient was not understanding. She just knew only Hindi. Okay. So examiner said, you can proceed, doctor. So when I just roll down the stocking, I see there is edema. There is pedal edema. When I press it, just with gentle press, patient just, try to scream like that. There is severe pain was there. I don't know. Probably examiner did not notice that. And I just become, scared. Okay, probably I'm going to lose this station completely. But I immediately seek apology. Should I proceed? Then examiner said, yes, you can proceed, no problems. Okay, you can skip this part. And by the grace of Almighty, I got 20 out of 20. So the message I'm trying to give you, if you already take the permission in a gentle way, you have weapon to justify. If you did not, then examiner could cut your marks. An examiner probably, I'm sure, they did not see that is there any tenderness presence or not. That's why they did not mind it and they give me 4 marks. So for any questions, any concern, any questions, any superstition you heard from different candidate or colleagues, anything? If not, I can proceed forward. Please be interactive. Okay, so no, so we discussed almost 2 station skill wise, and the last one is a very big one, right? Because it covers almost all skill. It covers almost all skill. Okay, so that is very important. 1, 2, 3, 4, 5, 6, 7. Okay, so every skill carrying 4 marks in total 28. I already discussed the 4 skill or 5 skill. Just I have to be a little bit explanatory in the clinical communication skill. In the communication skill, if you look at the skill, it's not about just communication or taking history. No, there's something more than that. If you look very carefully, appropriate and comprehensive history, what we usually know that, we all know that history taking is very important. It should be complete, comprehensive, touching the main points, excluding diagnosis, seek for or detect for any complications. No, fine. So far we know up to this point is fine. But the essence of impact, okay, during the impact in the communications as well as also clinical consultation, we also ask that. Okay, we ask that, no problem, we ask that. But the impact should be in 2 ways. How it impacting his daily life in the personal life, as well as also professional. So you should mitigate and address the issue separately. It is better, okay, because it is carrying marks. And in the communication skill, it is very easy to fail. You have to get 11 out of 16. So I would say be a little bit expressive here, little bit explanatory, okay? Dr. Faisal, just hold on. Please don't share the link with other people's because this is private group. Or I don't know why they are waiting. Just hold. Can you hold a few seconds? Can you hold a few seconds? Okay, just stopping. Okay, fine. We can move on. Can you hear me? Please correlate with me. Otherwise, the recording will not be completed. Okay. Can you hear me, Dr. Ashik or Dr.
Yes,
Okay, fine.
yes,
Yeah.
audible.
So we are moving forward in which, okay. Yeah, I was there. So impact is very important and identifying the patient's preferred management. This is very important. I'm pretty sure most of the candidate, even most of the mentor did not teach us in this way. You have to ask, there are these and these treatment options, which is very good. This also has some advantage. Which one you prefer? Doctor, I prefer for medication. I don't go for surgery. Okay, fine. But surgery is the permanent solution. If you take medication, you have to take for a long time. You have to say in this way. Then let the patient's choice their preferred treatment options. You are just as a, I mean, showman here. You can display the option, what is the benefit and what is the, I mean, pros and cons. Then you can and then let the patients actually choose the options. This is very important. So in clinical consultation, especially in the clinical consultation, please ask this. Okay. So there is these and these many options are available. Do you have any prefer or any preference to any treatment options? I'm pretty sure, and I'm telling you, in the real exam, they already calibrated. They will know, doctor, do best for me. What is you think best for me? So you already know that you know the answer. Okay. Skin is invisible. Okay. Let me share it. Yeah. Can you see the? Yeah. Now you can see. So I'm making it a little bit bigger. I know it's very teeny, but you can zoom in, no problem. So you can ask that, okay, which treatment you prefer? But they already said, okay, doctor, I have no preferred to any treatment. What is best for me? But asking is key here. If you ask that, you will carry the marks. You will carry the marks. Believe me, these are the tips and tricks. And with the little knowledge, to be honest, to pass phases is all about how far you know about the rules of the game. It's not about the knowledge. Okay, I'm going because I'm taking so much time. Explain clinical information in a clear, structured, comprehensive, and professional way. So you know many things, but you are not saying everything in a comprehensive way. For example, patient is diagnosed with rheumatoid arthritis. How we can say in the uh, concern part, for example, so I'm using this format. Okay, you have a joint condition called rheumatoid arthritis, one of the autoimmune conditions. Never bother with the medical terms. Where body defensive system become crazy in spite of attacking bugs, it attacks body own tissues. Okay, and unlikely to happen to your case. We are planning to start a medication to combat your pain. In the meantime, we'll do some tests, imaging of the joint. Once all the test results will come, we will form the team of doctor, including joint doctor. Finish. Do you have any other questions? This is the structure. You can say and follow in every case. And believe me, these teeny little things will make significant difference in your exam. After giving exam, the both colleagues say, okay, I got the diagnosis, but the difference is one will get 13 another person will get 20. And these things actually make this difference. Okay. Now, what is the pitfall? The pitfall which may lead to you to the unsatisfactory, okay, omits the important area of history. You cannot miss the important history. At least the key area you need to exclude. You know that we will discuss many things in the upcoming classes. I am not going deeper. Okay. Fail to assess an impact. This is important. How you are feeling. Doctor, I'm a retired person. I am a businessman. Still, how it impacting your daily lives, in your home environment, home life. This is important because they will try to hide you something you have to extract by taking history. Okay, unsystemic, already uses jargons. So I will give you a list of jargon and non-jargon in our personal group, inshallah. So you can master this area and try to practice yourselves. Okay, how you can minimize the jargon. Try always to explore and discover some non-jargon form. For example, any aggressive treatment. For what? Aggressive treatment is the non-jargon form of, in interventions or serious things or ICD or something like that. We can replace the word with aggressive treatment. Life-threatening treatment, right? App is unpracticed. Even you got diagnosis, you are more fluent, your spelling or fluency is very, very fine. Okay, you pick the all clinical signs, but it seems to be noted that you are not, practice well. Okay, you are shaky. You are just recalling and remembering your examination step during the examination or during taking history. This may lead to unsatisfactory. Please note it down. Unpractice. Okay, give unclear, insufficient information. You have to be clear and sufficient at the same times, and professional. And recently, I heard that many candidates appear in the exam. I'm talking about their outfit, and they appear in the exam with jeans pant. Okay, so I think everything is matter. So this unprofessional, outfit as well as also behavior may lead to fail in the exam. Be serious about yourself. You are not just appearing in the exam. You're going to be a complete human being, as a good physician, as a good doctor, as a good man. Okay, so fail to involve the patients in developing management plan. This is very important. I already said, when you are planning to manage, these are treatment options would like to offer. We can start with these, and this also very good. Which one you prefer? Doctor, what is best for me? Then you will get the control. Yes, we know there are not various treatment options, but you have to take this medication for a long time. But we think if we put some device in your heart, it will last a long time. You don't have to take medication all the time. So eventually he or she will agree with you. So it's not about you are going to confront, you are just making him aware. These are the treatment options. This is best. What do it? Okay. Fine. I'm going, sorry. Okay. Differential diagnosis, I discussed. Clinical judgment, already discussed. Patient's concern. This was, okay. The last skill we will discuss today. Okay. Patient concern. That's visible. Probably the skin right now is a bit more visible. And the skin is not completely visible. Okay, fine. You can see the pictures. Okay. In the clinical concern, it is very important how you are meeting the concern as well. Okay, so this is very important. So meeting concern means not just waiting for the patient's concern. You have to seek, detect, acknowledge. So do you have any questions or concerns so far? I'm going to tell you something for the next couple of minutes. Okay, if any point, if you have any questions, please feel free to ask. This is your defense sentence. If you say that, if they try to keep any concern within themselves, they will vomit. And after 3 or 4 sentences, started to say, do you have any questions so far? Any concerns so far? Okay. In the last part, even when the 2 minutes remain, you got the rank from the examiner. Just the social history. Do you have any questions so far? End with questions, asking and seeking and detecting. Sometimes patients or surrogate will not give you complete concern in a verbal way. They will give you some cool. I mean, you have to detect it. What is he's trying to mean there? Okay, I can see. Are you comfortable with this plan? No, doctor. I think that could be better. But you say so. These are the non-verbal. I mean, verbal, but very clue, and you have to pick it very carefully and look at the facial expression, what they are trying to say. So face tell everything. Okay, so try to seek, detect, acknowledge, address the concern in a very appropriate way. Why time frame is mentionable, you can mention, especially in the driving case. Okay, be empathetic, be an active listener. This is one of the most weak point we all have. We are not active listener. We're just passive listener. We're listening. We are listening. Okay, but in the real exam, as well as in your real practice life, try to be active listening. Try to understand, okay, what they are trying to say. Nod your head. Just make some sound. Yeah, I'm getting. Okay. Then this is very important. Teeny things will make significant difference. So active listening means you are just syncing with his thought at the same time listening carefully until he finishes. You should not start any talking. Okay. Then if the bad surrogate, okay, try to waste your time, you can use some weapon. Reverse psychology. There are 3 or 4 tips I will share on the communication later, but I'm sharing one thing right now. When the bad surrogate is taking so much time from you, you can say, okay, I know you're very, very upset and concerned, okay, about your further situation. I understand that. It's natural to feel in this way, okay. If you allow me 2 minutes and couple of minutes, okay, I can answer your all questions you may have, and you can ask me any questions. Is that fine? So after taking the permissions for 2 minutes, you means you already just shut up his mouth. Now you took the controls and it's your jobs. Try to be specific, be accurate within these 2 minutes because he will again come up with number of concerns. So try to be specific, give the appropriate informations, management plan, as well as also outcome of his father's condition or mother conditions. Then allow her to ask few questions. And if he asks question, then already probably we answer the questions within these 2 minutes. Okay. So outlook, okay, especially empathetic manner, okay, relatives understanding. Yes, always seek and try to understand, okay, did your father express any wish, any written document, any express any wish, any written document, anything he expressed, how he want to spend his last hour, any advance directive, any treatment plan, did ever he express? You should ask to his or her wife's daughter, relatives. Okay, it's very important. And just look at the scale, it is written here. So if you don't ask, they will cut the marks. Okay, poor listening, lack of empathy. So in most of the cases, I give the importance of tone. Tone is very important. Your tone usually present 2 things: how warm you are, how competent you are, and mostly how confident. The combination of these two will make you confident. So, for example, you are saying, "I'm sorry, doctor. I'm sorry, Mr. Hallen." Although you are saying sorry, but your voice is not telling sorry. You have to say, I'm really sorry for it. I'm really sorry. So your voice should say something, the sorry itself. Sorry is just not a word. It has some I mean inner image that called intonations, how empathetic you are. Probably I discussed a lot of things about the skill so far. If you have any questions, you can ask me. Then we'll go to the our next slide. Any questions? Try to be specific, try to be interactive. Okay. Dr. Tasneem, as well as also Dr. Hanan, any questions? Please feel free. Okay, there is no questions. So we can move forward. We can move forward. Just trying to make it a little bit. Okay. So how we'll practice the case in the upcoming days? Why I am just presenting these things in the first case, I'm not wasting your time. Our sessions might be extended from 15 to 17 or 18. I will cover 60 cases, but I just want to make the session interactive, make the session fruitful for you, because it's not about just arranging sessions and just giving some information. I want you to pass. Okay. So after role playing of any cases in our upcoming sessions or upcoming case, after a few minutes we'll discuss. We'll give detailed feedbacks according to the marking sheet. Point out your area of weakness where you can work on. Share the tips to overcome it, not to make same mistakes again in your upcoming active case. Okay, as well as upcoming days or sessions. Then you all will get the chance to ask any question regarding the case. Any questions, to be honest. I will try my best to give you answer. If I don't know, I will collect and share in the groups, because we are all learning. In the field of medicine, everyone is a student. Okay. So any correction, any questions, any additions, I may make some mistakes. Yeah, you can criticize me, correct me. I'm a student in the field of medicine. This is completely accepted. We are all learning here. I might make a mistake. Please feel free to correct me. So we are starting our first case. Dr. Hanan, are you there?
Yes.
Okay. So we'll practice 2 cases today, and from the next day we'll practice 4 or 5. So which station you want to practice today?
Any station.
Any station, no problem. Okay, fine. I'm giving you. Just hold on. I forgot the page number where I put the case here. Just I'm stop the sharing, then I will share. And just let me. Okay, probably. probably can see that how to perform the long clinical stations. Just I will take 2 or 3 minutes. Okay, then I will keep the case. Okay, because everything needs to be known, otherwise we cannot perform properly. Because before going to perform, understanding the game is very important. If you know the game, you already pass by default 50%. Then the 50% is just your task, your hard work, nothing more than that. Okay. So this is pyramid-like scheme I prepared according to my experience, what I understand basis. In any consultation scenario, try to start with the complaint. You already know that. You know that just I would like to give some touch with which symptoms patient presented with. This is the very important. If the patient gives some vague complaint, try to ask that what they mean by that. Doctor, I have some furniture. I'm so sorry to hear that. What do you mean by that? Then patient will explain everything, and after that he will ask few questions. And first, it is very important to categorize from which systems the symptoms is. For example, patient has chest pain. Definitely is going to be cardiorespiratory, right? So after exploring the first OD para or just the Socrates of any complaint, then you should explore the relevant system. For example, if it is cardiac, ask the cardiac questions very specifically according to the patient's complaint. Each question is very important because sometimes tricky and clever surrogate will give some information in a way. If you don't ask that questions, although it seems to be unrelated, they will not give you the information. So ask every questions of that system. Now, gradually, pyramid is narrowing down and moving forward. You have to be also narrow and make the time so concise, okay, and ask few more questions, okay, not in detail. Ask the questions to exclude your differential, what you make note from the outside. For example, patient presented with progressive shortness of the breath, 65 years, male patients. Please try to make it interactive. What are the differential we will think? Anyone can say? 65 years male presented with progressive shortness of the breath for last 3 months. Prior to 3 months, you were completely okay. What are the different? Yeah.
Cardiac or pulmonary?
We don't know. For progressive shortness of the breath, what are the differential you want to put? You want to, okay, from the respi?
Yeah, respiratory, yeah, and other cardiovascular.
Yeah. But in the respi, what will put first? Mention three or four.
Interstitial lung disease.
One by one, please. I will. Yeah.
It could be interstitial lung disease.
Okay, fine. Then 65 male.
It could be PE.
Pulmonary embolism. Okay, less likely. You have to explore the history. Fine. Okay.
Could be bronchial asthma.
Could be lung cancer.
COPD.
Yeah. Yes, common thing. I always prefer to use a code. It's my realization about the patients. Please make peace with patients. Don't be serious with the patients. Make peace. Common things common in patients. 65 years male, what could be the common? We don't know about the recent flight or any surgery. We don't know. Yes, surgery will guide you pulmonary embolism. But why you are thinking first? IFA, very good one. You said that. You got the diagnosis. And what exactly was my case? When this form was given, I was prefixed from the outside before entering the exam hall, room. I was pretty sure it's going to be IPF. And patient was IPF patient. Okay, so number one, IPF. Number two, yes, it could be COPD. Patient not necessarily has to be smoker due to dust, different in occupational, injurious materials, carbon, radon, coal, dust can cause COPD, right? So COPD, why not COPD? Second, lung cancer. In elderly patient, any cancer is common. Okay, so it could be other few things from other system, cardio. It could be just simple pneumonia. Okay, it could be some just few other things, malnutrition, weakness. Okay, respiratory muscle
Infection.
problems, anything. But common things is common. Okay, so very good, Dr. Hanam. Now, this have to be, I mean, your differential from the outside before entering the room is very important. Why, you may ask and think that, doctor, why you are taking so much time to explain everything? Because I know this is very important than the case practice. Definitely we'll practice a lot of case. No problem, no doubt at all. I will explain and extend my sessions. Probably, if I can compensate all the case, it might be 16, 18. I will cover everything, but I need to know to give you this information to you. It's very important. So ask the questions to exclude differential from, and you should write it down within 5 minutes and make a plan how you want to meet the concern and what's your management plan. If the case is acute, how you will meet the concern. If the case is chronic, how you will meet the concern. It's all about preset and mindset. This is all about peace of mind. If you peacefully think, okay, what I'm going to tell, what I'm going to plan, it's very easy. It's very easy. Okay. Check and ask any complications. This is also a sign of good candidate. You already got the diagnosis of IPF. Examiner is also happy, but examiner will be more happy if you ask for complication. What are the complications? Ask about any leg swelling, any shortness of the breath along with some chest pain, any puffiness of the face or any other things, any tender hepatomegaly, any abdominal swelling, any other things. Okay, you can ask that. And during examination, you should also demonstrate that you are taking palpable P2, you are taking and raised JVP presence or not, basal crackles, pedal edema, tender hepatomegaly. Okay, so it's a sign that you are a good candidate. So to be honest, what I learned actually, this is all about your appearance, how professional you are, how fluent you are, along with how you are keeping the wide visions. Okay, they will notice it. If you notice the complication, if you make mistakes during some cross question, still they will give full marks because they know you better from your examination and history taking. Probably you did not get the answer during crossing, but definitely it's a matter of just opening the books. Probably you will know that. They will think in this way because in the cardio and neuro, I make teeny mistakes or I could not answer all questions. They could give me 18 marks. I could be happy, but they gave me 20 out of 20 in both stations. And what makes me feel that actually they actually assess as a whole from the starting the examination, dealing with the patients, and lastly presentation as well as also other things. Okay, so systemic review is a very focused way. If not relevant, you can skip that. So in the conventional mentors of different parts of the world, they sometimes say, okay, take some review. I don't prefer, because if it is guiding, this is systemic sclerosis, it's very important to seek for complications. Is there any pulmonary hypertension presence or not? Is there any IPF, lung problems presence or not? Is there any bacterial overgrowth syndrome presence or not? Is there any renal crisis presence or not? Rather than just someone is focusing few other things. It's not necessary. So that's why I just keep it in the yellow color. You can skip that if you don't think this is important. But if you think I have time, I would like to just want to demonstrate the examiner that I'm touching the review, systemic review. You can ask one question from every system, especially the system is closely or far related. If the system is far, from your, complaint or from, you can completely avoid that. If it is just related or can be related, you can ask one or two questions. Just demonstrate the examiner that you would task that. That's it. Seek, meet concern in a precise way, ask for second and third one. Sometimes most of the candidate thought and actually stop after meeting the first concern. Okay, they take the concern in the last moment. They have usually get 1 minute or 30 seconds or 45 seconds. They did not get the chance to meet the second or third one. But in the real exam, they keep some concern, at least 2 or 3. So meeting the concern is also a skill. For example, I'm checking, anyone can correlate with me because I want to make it interactive. For example, the patient is IPF. Doctor, is it cancer? Anyone can meet the concern? Please be interactive. Feel free. I just want to make it interactive. Anyone want to interact? No one, right?
Yes.
Yeah.
I highly appreciate your feeling that it is not cancer, but it is the condition in which there is misdirected immune system which is supposed to attack the bug, but in your condition it attack your lung.
Dr. Ashik Bhaiya, for which
Yes.
disease you are meeting concern? IPF?
Yes, IPF.
Okay. Okay, fine. Now carry on.
Okay, it's supposed to attack the bug, but in your condition it attack the lung and skin and bowel. That's why you are having this symptom.
Okay, fine. I'm not happy with the answer completely, but I'm just saying, if it is said, Doctor, is it cancer? Your concern will be.
Sorry, Doctor, may I know what's the question?
Okay, I'm again asking the questions. For example, I'm suffering from interstitial lung disease. There is no underlying cause. I'm just making it simple. Underlying cause. I'm elderly 65 years patients. Okay, now I'm asking. You already examined and talked to me. I'm asking, Doctor. You asked me. Okay, do you have any questions or concern? My concern is, Doctor, is it cancer? What will be your answer, Doctor?
Okay, so you reached a diagnosis of interstitial lung disease, but still not confirmed. Is it the case?
No, already you got the inspiratory fine crackles. You excluded all connective tissue disorder, which is not there. A patient has no smoking history. Everything is given to you. You are thinking it's going to be an IPF case. Now, patient asks that, Doctor, is it cancer? What will be your meeting concern? My concern word.
I can say that I highly appreciate your concern. Cancer is one of the possibilities, but from the history that I took and examination-wise, it seems like an interstitial lung disease, which is blah blah blah.
Okay, fine. So the first part was very good. You appreciate my concern. This is also a very good sign. I appreciate that. Okay. But the way you made the concern, I think we could make some improvements. How? I asked, Doctor, is it cancer? Please be precise. As you are not thinking cancer, you don't need to tell them. Yes, I'm happy. I highly appreciate your concern. We don't think it's cancer. Okay, there is no sinister symptoms we got in your case, but we'd like to exclude by doing some imaging. This is the answer. Do you know why? You are not excluding and keeping out the cancer outside, but you are saying in a way patient will get some relief. Okay, yes, doctor, I'm not cancer, but you want to exclude it. That's fine. But to be and exactly the same sentence is written in the rider. Rider is a very good book. I don't know many students why don't follow the rider and say rider is a old book. No. Meeting concern, if you want to master in the concern part, read rider. Okay. So Because I said, doctor, is it cancer? You took all the history, examine me. There is no smoking history, body build is fine, there is no weight loss history, there is no hemoptysis. Why you are still saying it could be a cancer? Better we can replace the sentence, but the meaning will be the same. Yeah, we are not thinking cancer, Mr. Jack, because we did not get any findings, but still we would like to exclude, okay, by doing some imaging. The same meaning in a different way. Did you get my point, Dr. Tasnim?
Yeah. It's same
Okay.
meaning, but in different way. Yeah.
Yeah. Okay. So any questions, concern? Dr. Tasnim, probably you raised the hands. Okay. So do you have any other questions?
No.
Okay. So, in that way, you can put what you are not thinking, but there could be possibilities you can answer in this way. No, we are not thinking. Yeah, that could be, but it's bottom in our list. Would like to exclude by doing some test. Finish. And the answer should be that your answer yes or no should be the first. Then you can explain. For example, doctor, is it cancer? The answer could be 2. The good good candidate will answer in this way. No, we are not thinking a cancer, followed by description. Yeah, it could be possible. It is minor chances there. I would like to exclude by doing test. But the bad, unexperienced or unsatisfactory, or you can say the unexpert candidate will say, yeah, it could be a possibility. There are a few other things we are thinking, but you are not still saying the right answer. Is it yes or not? You are just, following in the midline. An examiner is very experienced in this field. They're noticing you are not clearly saying yes or no. You're just saying and just following a diplomatic pathway. Yes, it is better to follow that, but not in all ways. When you already excluded, there is no chance, there is no weight loss, no smoking history, no COPD pre-existing, no familial history, no hemoptysis, no lymph node, no wasting. How you can say cancer could be, although it's rare? No, you cannot. I would say it cannot. So that's my recommendations. Start with yes or no, followed by short description. Seek, meet the concern in precise way, and immediately after finishing, do you have any questions or concern? Because you don't know when time will run out. Now, next slide. Our plan of next 14 to 15 sessions. Session day, Tuesday, Thursday, Friday, Monday. This is our, tentative. Hopefully we'll continue in this way. Time will be 2 p.m. GMT with 30 minutes variation. Reserve right, we reserve the right to cancel a session due to unexpected and unavoidable situations with prior notification. We'll compensate it later. We'll practice 4 cases per sessions, okay? Sometimes 5, depends on. Now, starting with the first case. Dr. Tasnim, are you there?
Yes.
Okay. You will take 4 minutes for your preparations. Then let me know when you are ready.
Could I take after a while, because I can't do it now. Sorry.
Okay, no problems. No problems. So, doctor, just let me check. Dr. Hanan, are you there?
Yes,
Okay. So, can you take the case?
sure.
Yeah, sure. Thank you. So this is your case. You can take typical 5 minutes format, make some notes, make some differential, then let me know. We'll give you 30 minutes for the online purpose. In the upcoming days, what we will arrange, we'll make some pictorial, audio, different things. But for today, I'm sorry for that because there are a lot of things I have to do. That's why I could not, but I will say everything from my side. but from the next day you will get pictures, relevant pictures, findings in the slide. Okay. So you take preparations, then we'll start. Okay, your time up for preparations. Then you can start. Your time starting. Dr. Tasnim, are you there?
Dr. Hanan.
Your time
Hello?
start now. Yes.
Hello, I'm Dr. Ali, one of the doctor in medical ward. May I confirm your name and age, please?
Well, Doctor, I'm Mr. Daniel Still, 63 years, doctor. Nice to meet you, doctor.
Yes, welcome to our clinic. And how would you like to be addressed?
Well, you can call me Still. Still is fine. Yeah. Doctor, actually, I have been referred by your GP, okay?
Yeah.
For the last few weeks, I'm noticing some blood in my cough. Okay, initially I just neglected. I thought it could be due to something, some infections or something like that. But it's happening very frequently for the last few days. Okay, and it's also associated with my shortness of the breath, as well as also some cough, and that's actually bothering me. I went to the GP once again. He did some tests, but could not find out anything significant. That's why he sent me to you for the evaluation.
Yeah, Mr. Seal, sorry to hear that you have a very tough time. And I'm glad you come here today so we can figure it out together.
Yeah.
Yeah, just I would like to, while we are talking about while we are discussing your condition, I may take some notes that will be completely confidential, and maybe asking you a private question also will be confidential.
Yeah, you're fine. Yeah.
Yeah, so you said all this complaint started just 6 days before. Before this 6 days, are you quite well?
To be honest, it's a worsened for the next 6 days. I mean, last 6 days. But actually, it started, I would say, few weeks, 3 or 4. Okay. But it was tolerable that moment. But for the last few days, I cannot cope up with my daily activity. All time cough and shortness of the breath. And the most important part is scaring me. I mean, blood in my cough.
Okay. So the whole process, the whole symptom started 4 weeks ago. Is it of gradual onset or
Yeah,
rapid onset?
I would say initially it was gradual, but for the last 6 days, it is actually a little bit worse.
Okay. So, Mr. Steels, you are complaining of cough, shortness of breath, and this coughing of blood. Which one started first?
Okay. I have been coughing for a long time. Okay, so cough is not an issue for me. But shortness of the breath actually made me aware that I should go to the hospitals. I planned for that, but the vomiting, I mean, coughing of blood, that actually makes me so frightened. So that actually pushed me to come to the hospital.
Yeah, you are right. I do appreciate your feelings. And you said this cough, is it dry or you produce phlegm?
It's produce phlegm along with blood.
Okay, and what can I know the amount of that phlegm?
One
Is it a
cupful?
cup?
Yeah, one cupful in a day.
Okay, is it related to certain position or yeah?
No, to be honest.
If you are just bending down to pick something or
No, not really.
okay, and does it have a specific odor?
Yeah, sometimes it smells very nasty.
Okay, does it contain any mucus?
Not mucus, I would say it's cough. Yeah, sometimes, yes, sometimes some mucus is there.
Okay, and also you say you have shortness of breath.
Yeah.
Does it occur at rest or with activity?
To be honest, during rest, I can't feel anything. But when I try to do something, go for a walk, okay, that time I feel some catching of breath.
Can I know how long do you walk before and then you get this shortness of breath?
Hardly 100 years.
Okay, and this coughing of blood, is it bright red blood or just coffee ground?
Yeah, we raised a very valid question. It seems to be very bright, doctor, and that makes me so much anxious.
Yeah, I understand your feeling. Anyone in your place will feel the same,
Yeah.
scared of blood. But I'm glad you are here today, and we will do our best to help you.
Okay.
So, just I would like to ask you, do you have any fever?
Yeah, sometimes, doctor. Yes, for the last few days, I'm noticing my body temperature is a little bit raised. Okay, probably you have been given the informations. Look at the temperature, doctor. Yes, there is some feverish.
Okay. Before this, you do not. Yeah, you don't have document, right?
For the last few weeks, I noticed that the fever is not continuous. Sometimes comes and goes, but it's tolerable, not severe.
What about your appetite
I completely lost it, doctor.
and any change in your weight?
Oh, I'm one of my colleagues said I'm getting slim day by day, and I lost
Mhm.
5 kilogram over the last 1 month.
Okay, is it intentional or non-intentional?
No, nothing, doctor. I'm trying to gain weight, rather I'm losing, doctor.
Okay, any change in your diet or exercise?
No.
Any lumps or bumps in your body?
I did not notice too. You can check it, doctor.
Okay, any night sweat?
Night sweat? No, I don't think so.
Uh, um, have you traveled abroad?
Abroad. Hey, it was 10 years ago, doctor. Last one.
Okay, okay. And have you ever experienced any chest pain?
No, not chest pain, but when I cough, I mean vigorously, that time I feel some discomfort, you can say, not pain in the chest.
Okay,
Yeah.
okay. Any chest tightness?
No,
Any lightheadedness?
no.
Any swelling of your legs or your abdomen?
Swelling my no, there is no swelling in my abdomen. There is no swelling in my legs.
Does people around you tell you that you look pale?
Sorry?
Does people around you
What?
tell you that you look pale?
Yeah. Yeah. Well, I have been said, yes, I'm getting pale day by day.
Okay. I would like to ask you about your past medical history.
Yeah, sure.
Yeah. Any long-term disease that should be aware of?
So far, I know there is no long-term conditions I had.
Okay, or you hospitalized before?
Yeah, in my lifetime, to be honest, one time I was hospitalized. It was 10 years ago.
Okay. Do you have any allergy to drugs or medication or food?
No.
Okay. Any similar condition in your family?
To be honest, my father is diabetic. My mother is also diabetic and hypertensive, but they are living well. Nothing so far, so problem. Yeah.
Now I would like to ask you about your social history.
Yeah.
And maybe I ask you a private question that will be confidential. What do you do for a living?
Yes, doctor. I'm a retired person. I'm just running my business. Okay. I have a factory and just sit and work and give instruction. That's it. Nothing big deal.
Okay. So you are a businessman.
Yeah.
Okay. And how this complaint affect your daily activity and your work?
To be honest, it's impacting a lot. Okay. Even when I try to give instructions to my co-workers, I have to catch my breath, so I cannot move and work. And that's actually bothering me in my personal and also my business area.
Sorry to hear that. Yes, now I would like to examine you, and I will ask you some questions during my examination.
Yeah, sure, you can.
Okay. The vital signs, any change or like the previous one?
No, it was same.
Okay, now I would like to, Mr. Steele, could you please remove your
Yeah.
upper part? Okay, and I will lie him at 45 degrees.
Yes,
and
45
they will-
degrees. Yeah, patient is there. You can proceed, doctor.
Okay, can I see your hands? Can you raise your hand like this? I'm looking for clapping.
Yeah, there is clubbing his presence.
Okay, any nicotine stain?
Patient has nicotine stain also there.
Okay, and Mr. Steele, how many cigarettes do you?
Yeah,
Doctor,
I quit it 5 years ago.
Okay, that is. May I know why you quit it?
Sorry, may I?
No,
Yeah, I
why
quit
you
it.
quit it?
I quit it because I think, and I saw in different articles, it's injurious for health. Okay, and doctor also said it would be better if I quit it.
Okay, I'm proud of you. And what about, do you drink much alcohol than normal?
Within the social limit.
Okay, sorry to ask you this. Have you ever tried recreational drugs?
No, ever.
Okay, so now can I see? I'm looking at the dorsum of the hand to see if there is any muscle wasting. And
There is no muscle wasting, only clubbing is there. Patient has no other findings in the hands.
Okay, and after that, any flap?
You have 2 minutes left.
Okay, any flap?
No flap. There is a patient is anemic.
Okay, I'm going to examine the chest.
Yeah. Okay. You are
okay,
examining in the upper part, right? In the upper part. Yeah.
Yeah. I will start posteriorly.
Okay.
I will check for expansion.
Yeah.
Any reduction?
Okay. Chest expansion is normal in both sides.
Okay. Percussion. Any dullness?
Percussion is also seems to be normal.
Okay. Auscultation.
In the auscultation, I mean, right side is some crackles is there.
Which area?
Right middle region, doctor.
Okay. Any scars at the back?
There is no scar.
Sacral edema.
No.
Okay. Auscultation.
In on auscultation, there are some crackles, which seems to be, I mean, biphasic. Okay. Yeah.
Any bronchial breathing?
No, there is no bronchial breath.
Okay. I will check lower limb for edema.
No, there is no limb edema.
What is your concern, Mr. Steele?
What's wrong with me? Is it cancer?
Mr. Steele, I highly appreciate your concern. I don't think it is a cancer from what you have told me and examined you, but also, but it is one of our differential diagnosis. We put it at the bottom.
Okay. So what's wrong with me? Fine. You said this is not cancer. That's really reassuring. What you are thinking in my case?
Yeah, from what you have told me, most probably you have a chest infection.
So, I mean, doctor, I'm wondering, I was fit and fine. What type of infection that led me such kind of, I mean, coughing of blood and something I'm actually not getting clearly, doctor. Can you specify? Your time up, Dr. Tasnim, but I'm giving still 1 minute so that you can complete your task. Continue, please.
Yeah, from what you have told me, before you are before you are a smoker, and now we present with this large amount of sputum with blood. So just in my mind that most probably you have a medical condition called bronchiectasis.
Bronchiectasis, okay.
Or abscess. Actually, I have differential diagnosis, abscess or bronchiectasis.
Okay.
So
your time up.
Yeah.
Your time up. Your time up. Just hold few seconds. I'm giving the feedback.
I thought that you are going to tell me your 8 minutes finish, your 6 minutes finish.
Sorry, I did not get you. Sorry.
Yeah, the history and physical examination time. I thought I'm going to hear you saying to me now 6 minutes pass or 7 minutes.
No. In the real exam, they usually give you just alarm at the 30 minutes.
Yeah.
Okay. 30
Yeah.
minutes. Okay.
Yeah.
Just hold a second. I am.
Mm.
Fine. I'm sharing the slide. This was the scenario. Well done. You good attempt. Okay, so you almost near to the diagnosis. That's fine. Good performance. But a few things is missed. And for the sake of discussion, for the sake of passing MSCP, we have to criticize. Please don't take it personally, because I went through this phase. I know it's very important. Okay.
Yeah.
So be open. We are not here to attack or something. Just I'm trying to be a good surrogate for you in the real exam. Okay. So I will just
understand.
Yeah. I will give you complete feedback one by one. So your starting was very fine. I am amazed by that. You starting with name, then how you want to be addressed, and how you can help me. That was fine. But I would say be short in this part because the time is very limited. I also say it is not necessary and mandatory that you're going to take some notes. It would be confidential. Please don't make it as a habit. Don't make it as a habit. It will cost you time. It will cost you also attention, because you have to go and forth in your note. An examiner will note it down, that you are not pre-plan in your mind. All you just put on your note. Okay, so it's not sounds good as well as also looks good when you talking with the patient at the same time, looking into the script on a frequent basis. Try to rehearsal yourself within 1 minute, in the last 1 minute before entering the exam hall. I already said that. Yeah, definitely the note is there. You can look 1 or 2 times, but not more than that. Okay, fine. So you can minimize your time in that part. You can skip that. I'm going to notes. That would be confidential. Okay, you can skip that. But if you say try to make it a fluent way, okay, I'm going to make some note. It would be confidential. Okay. Can you tell me what brings you here today? Then patient will say the symptoms, okay, and you can explain more, but you will take some time. I will discuss the case fully, but I'm just saying the pitfall. In the one time in the history, there are a few jargon I noticed, which is very important. We can address it. Okay, mucus itself a jargon. We can call something fluid. We can call flame. We can call some slim. We can call in many ways. Okay. And abroad. When I say, okay, did you visit abroad? Yes, that was one of the pitfall. Okay, you can clue. You can say, yes, I visited abroad 10 years ago. You should explore that. It was uneventful, or before or after returning back, did you experience any infections? Then why you visited? It's very important, because as it is the system of respiratory, some respiratory infection is very common among the travel, especially the TB. If you ask more, I would say I travel India doctor. So that's why, and from where I catch the TB. I could say that. And you asked me, did you ever visit hospitals in your lifetime? Yes, I admitted one time. You did not explore for which condition. Did doctor say any particular diagnosis? That time I was diagnosed with TB and I completed my treatment. I was completely fine. That was my calibration. Yeah. In
I
the
didn't hear it. Yeah.
sorry.
Yeah, I didn't hear it that you say you have been admitted.
Oh, I'm sorry for that. Okay, I will be more clear, no problem. So and that was the things, and I also noticed that you're taking history fine, system wise. Just later on, you jump to another systems and then come back to your main system. So I think we can work on more to be arranged way. Okay, so we definitely will touch the other system as well, but finish your first main system, then go to the other systems. Be a little bit systemic. And in the examination, during the examination, you start the examination just after taking the hands or few other things, and then again take the history. I would suggest complete the examination part, then come back to the history if you think there is some history is left. But don't do simultaneously, because as a human, we can't do two things at a time. Okay. And smoking in the social history, you ask that. And the last part, okay, when I say, doctor, I have crackles, you did not ask, okay, is it fine or coarse? You did not ask, can you give a cough for me? Okay, that was the clue. I actually kept it according to my calibration. But
was rushing.
as it is learning in class, hopefully everything will be overcome in your upcoming session, no problem. From the time management, I would say you could be a little bit speedy, no problem with that, because you started examinations at I would say 11 minutes, 11 or 10 minutes or 30 seconds. I always recommend to my all fellow candidate, all doctors, okay, try to start your examination just after 7 minutes. Okay, because you don't know what is waiting for you. There might be many findings, many concerns might be, okay. Go for that. And then you have always opportunity and chance to back again, ask the questions. It's not restricted that you have to take the full history, then examination. No, you have full flexibility here. And another things I would say to Dr. Tasnim,
Sorry, doctor, I'm not the one who presenting the case. It's Dr. Hanan.
Yeah, I will give you the scenario. Yeah, sorry. Did you, Dr. Hanan, can you say something? I mean, I did not get your point.
I mean,
No.
the doctor who presented the case is Dr. Hanan, not me.
Okay, your name, sorry, I'm sorry. You are Dr. Oh, I'm performing with the Hanan, right? Sorry, I'm so sorry. Okay, I have to memorize your name. It's very important. Okay, Dr. Hanan, are you with me, right?
Yes.
Okay, sorry, I'm extremely sorry. Okay, so
No, because you gave her the case first. This is why.
okay, fine. So Dr. Hanan, I lost the flow. Okay, fine. So
the crepitations.
crepitation, yes. And after the crepitation, it is better to take the trachea just in a quick view, okay? And you can take and palpate the pulmonary area to exclude what? To exclude the complication. I always say try to exclude the complications. Patient might have some pulmonary hypertension. In any respiratory case, it is very important. Then you checked about the pedal edema. That's very good. In my calibration, yes, patient may present it with amyloidosis, okay, long-term complications. But other things also need to ask. If you catch the diagnosis in the very first, you could ask about any malabsorption, loose motions, as well as also school performance. What about the other siblings and childhood infections? Yeah, and checking the NIP node is very important. I don't know you would offer me or not. I during the history I said you can check it, but in my calibration I kept it that you should check it, but probably you did not check. No worries. It's
I was rushing.
Yeah,
I don't have
and that's
enough
why I'm
time.
saying time management is very important. So
Yeah.
I'm now sharing the tips and tricks how you can manage the time in any scenario. Okay. Now then I will get to the full feedback. Okay. So when in the places you are not getting any clue in the first 2 or 3 minutes, during the conversation, you have to mentally prepare that something a difficult things is waiting for you. God sometimes will not favor in that sense. Not easily you will get the diagnosis. So something going to be challenged. Change your default system. What is default system? We are taught to take all the history, auditor, then systemic, and then exclude the diagnosis and seek seek for any complications and PDF. Okay. But when you are not getting any clue, go for PDF after 2 or 3 minutes or 4 minutes. Don't waste your time because you are not getting any clue. Probably the clue in the PDF. Past history, make it very clear and very detailed. Do you have any past medical history I should be aware of? Doctor, I don't know. And as your system is respiratory, any chest problem, any chest infection in past or present or recent or any childhood, you should ask that. Any contact with TB patients? No, fine. Any other family members, what they are suffering from or any chest problems? No, fine. Any recent surgery or surgery, any procedure? Any procedure means many things. IV drug, IV blood transfusion, tattooing, dental procedure, everything. Okay, so it's very important. Any surgery, any procedure. Drug allergy is not always necessary, but if you can ask, that's very good. But I would say, as time is limited in the respiratory system, you have to ask few other things like any pet in your, especially if the case is just cough, shortness of the breath, any pet, any allergy to the pollen, yes, definitely. But when the problem is some hemoptysis, you have to ask few more. Okay, some other things like any pulmonary embolism, you ask that. It could be TB, it could be lung cancer, it could be also some vasculitis. Okay, so some nasal features, some ENT features also there. Is there any sinus problem, any nasal crust, any bleeding from the nose? Is very important. So in the examination, I would say start with a general view. Okay, look at the patient, look at the statue, especially in the bronchitis patient is very easy to detect. There will be a bedside spot. Sometimes they keep it or not. But when you will say by standing on the bedside, can you give a cup for me? I would like to give overall impressions. If this impression is not only impression, you are offering a cup. When patient is trying to make some cup, he would not stop. Do you know why? In bronchitis patients as well as also IP patients, they don't control over their cup. If you offer one, they will give 3 or 4 continuous, and sometimes they will expel some cough in the sputum, and this is a very big clue. Okay, there's going to be something bronchitis or something COPD or something lung carcinoma line, not IPA. Okay, then you can go to the patient, start with the hands very rapidly, take some clubbing, they start the calibration, because case-wise few findings is very specific. But when you did not get the case or impression, then you will lost. Okay, there might be other things I'm missing. No, look at the hands. Is there any flap? No. Is there any clubbing? Yes. Look at the palm. Is there any feature of pulmonary erythema presence or not? Okay, fine. Then go upward. They look at the neck by asking, turn to the left. Any raised JBP. Look at the face to see any anemia. Okay. Open the mouth to see any dehydration or any cyanosis. Then go to the back. I'm going to check your neck length. Is there any neck sore? Seek permission in every step. That shows you are gentle. You are a very good professional doctor. I'm going to touch your face. I'm going to check your neck. Is there any sore, any pain in your neck? No, doctor. Be relaxed. I'm checking. Then go to the back. Have a good observation. Is there any scar in the back or any skeletal deformity? No, fine. Can you take deep breath in and out? It's not enough. Show it, demonstrate it. Okay, can you look at me? Can you take deep breath in and out? Just open your mouth for me, just like me, follow me. And just demonstrate. It will save your time. Otherwise, you have to every time say, can you take deep breath, deep breath, deep breath? No, demonstrate it, because they don't know how much frequent and how prolonged the respiration should they take. They don't know. You have to demonstrate it, and to elicit the appropriate finding is very important to give the right comment to your patient. Okay, then you take the expansion and check extensibility. I would say it's not needed at all, because you don't know that's how many times you have. You better go directly to the auscultations. Just after a good look, go to the auscultations. Then auscultations, when you get the crackles, you should always have to two things. One, give me a cough. Give me a cough. Two, you have two things. The crackles is uniphasic or biphasic. If uniphasic or biphasic, is it fine or coarse? There are few things so you should give complete attention when you gave the crackles. Then check symmetrically both sides. Is it localized or both sides? Is it in the upper or middle or lower zone? Okay, then you will get the clue. Definitely this is very easy in this case. This was localized to the right side. Then come forward. Okay, I'm going to check your windpipe. Okay, it might be a little bit discomfort. I'm sorry for that. Check it, any deviation now. I'm checking the palpable P2 area. Okay, then I'm listening any loud P2 is there or not. Look at the abdomen. Is there any visible mass? No, although it's not needed. Just have a good look. Okay, go to the pedal end. With the permission, do you have any pain in the ankle? No, doctor. I'm going to press it. Okay, is there any pedal edema? During pressing, don't look at your hands. Look at the patient's face. It's very important. Examiner always notice it. Okay. Then you can come up with a collective thought. Okay, probably you got the diagnosis. Then you can ask few other things in social history, anything. Okay, and up to this point, when they are not saying you have 2 minutes left, you can ask few other things. You can exclude few other things that can carry some most recent travel, like sexual history. Okay, any childhood infections. Okay, any other things you can ask that. Then when say 2 minutes left, stop everything. What's your concern? You already asked that. Then explain. Okay, is it cancer? If in my case, my case was IPA. Patient said, "Doctor, is it cancer?" When I said, "Doctor, what's your concern?" Patient, I asked the patient. He said, "Okay, is it cancer?" It's easy because it's a short concern. No, we are not thinking cancer because we don't find any symptoms in your case. However, we would like to exclude by doing some imaging. Do you have any other questions? So what's wrong with me? So you have a condition we call in a medical term idiopathic pulmonary fibrosis, where there is some scarring happening due to unknown reason. We have to do some tests, involve the chest physician, will prescribe some medications, you may need to some oxygen, and so on. Okay, then I noticed that there is no concern from the surrogate side. Okay, they make just two concern. So this was the full feedback from my side. So any questions so far from the Dr. Hanan? Then I will.
No, I'm good. Thank you.
Okay. So usually in the case of bronchitis, patients has pre-existing history of TB, some childhood infections, okay, as well as also few other causes like lymphoma, carcinoma, some connective tissue disorder, okay. There are lots of causes. You have to look for that. Even in this scenario, patient has rheumatoid hands, you can correlate with this bronchitis. So Dr. Hanan have no questions. Any questions from other candidate? Please feel free. Make it interactive.
Sorry, what is the differential diagnosis for this case?
Yeah. For the differential diagnosis, it's very good questions. I'm coming to the next slide. For the differential diagnosis, what could be the differential? Lung carcinoma is a very potential. Any cough along with hemoptysis in a pre-existing or previous history of smoking, lung carcinoma is a very good differential. Patient is elderly, has clubbing, everything is suggestive. Okay, but the infection, recurrent infections, goes in favor with bronchitis. Biphasic natures of the crackles course goes with bronchitis. localized area, right? But in a COPD patients where we expect lung carcinoma patients along with COPD, there are some vesicular prolonged expression, polyphasic, but in the carcinoma setting, monopolyphasic which can be present. There will be collapse or pleural effusion. These are the most common findings in background of lung carcinoma. But in this scenario, this was bronchiectasis. Okay, so I'm now discussing and crossing a few questions so far because we have to move forward. So Dr. Hanan, what investigation you want to do for this case?
I will start with laboratory investigation, complete blood counts, and inflammatory markers, ESR, C-reactive protein, renal function, electrolytes. And imaging, I will start with X-ray, chest X-ray, and high resolution CT scan.
Yeah. In the X-ray, what did you expect in the X-ray?
And the X-ray, I can see. I will see reticulonodular. No, I will see tram-shaped appearance of dilated bronchi.
Yeah.
Yeah, a reticulonodular schedule and tram.
Okay, fine. Okay. Then
and high resolution CT scan, it can give more details.
Okay. How you want to manage this patient?
I'm going to admit him to the ward, and I'm going to educate him and counsel him about his condition, and also we are going to involve multidisciplinary team that include chest physician and bugs, the infectious team also, and specialized nurse, physiotherapist, and also I'm going to send him for pulmonary rehabilitation and advice for vaccination.
Yeah. Okay, fine. Thank you.
Pharmacological treatment.
Yeah, mention, please.
Yeah, I can give him broad spectrum antibiotic, waiting for the culture and sensitivity of the sputum.
Yes.
And
so,
we should be well hydrated.
And last one, well hydrated. Okay, fine. I got your point.
Yeah.
So you did very good investigations panels. That's very fine. But I would say make it a habit to make it bundle of 4 or 5. Because in the real exam, to be honest, they don't like to be said in a way. I would like to do complete blood count, ESR, reactive protein, basic. No. It means we are just saying from subconscious. Okay, it's already preset. Okay, in my real exam, they say it. Okay, what do we expect in the CBC in a case of heart murmur? Yeah, I caught behind. Okay, because they expect something you are specific. Yes, you can say. I'm not saying you cannot mention. You can mention at the end. Be specific in a way. Make bundle. Because when you try to remember all stuff, your important list will be gone away. This is human. Okay. But if you make the list, I will make and remember these 4 first. If time permits and if they ask more, I go for later. In my LCC, another LCC, patient was young, aortic stenosis. I'm saying general management and pharmacological, but examiner repeatedly saying, okay, what is the definite management? I'm saying I have 4 minutes. I'm reminding myself, okay, I have 4 minutes. I'm going to there, but they are asking what are the different. Definite. So I would say, you can say in a way to confirm my diagnosis, I would like to high resolution CT supported with chest X-ray. To confirm my diagnosis, that to detect the nature of the disease, is it obstructive, restrictive, pulmonary function test. To detect the underlying complication, you can say ECG, echo, okay, urinary protein for amyloidosis, ABZ for respiratory failure. You can mention that. And to see the other complication or to see the other associations or routine blood test, renal function test, liver function test, you can say that. but you are still not saying what might be the underlying cause of this bronchitis.
Yeah.
So you have to say something. I mean, infection screening is very important. TB screening is very important. Aspergillus precipitans is very important. Autoimmune antibody is very important, especially ANA. Especially ANA is very important because they are waiting for that. So when we will say and make it default, routine blood test, liver function test, renal function test, our brain say, oh, you already said many things. Don't need to there. How our brain works. But if you are become specific, I will mention these 4 bundle first. If examiner seek more, then I will say more. Okay. Because these are the carrying marks. To be honest, routine blood test is not carrying marks. Routine blood test is not carrying marks. Okay. I already demonstrate, okay, in the satisfactory part, they mention accurate, clear, appropriate. Okay. So that's why I make bundles. Same things in the management plan. Okay, just if you want to say general, yes, be fast. Patient education counseling is very important because patient has all right to know about his condition. Nutrition build-up, vaccination, quit smoking, as well as pulmonary rehabilitation. In cardiac rehabilitation must. They want to hear it. All the symptomatic relief, yes. Some active therapy. I said A, B, C, D. A for antibiotic. Probably patient has some infective exacerbation. B for bronchodilator. C for corticosteroid. There is severe exacerbations. Okay. Then D for diuretics. For what? To combat the complications or corpulmonal patients, if patients have. Okay. So what are the complications, Dr. Hanan, in case of bronchitis? There are mentioned few complications.
Corpulmonal.
Fine. Then?
Amyloidosis.
Okay.
Respiratory failure.
Yeah. Fine. Thank you. I'm expecting 3 most, and that's very good. Yes, there are few complications in respiratory is very common. That is, you can make it default. Pulmonary infection, recurrent pulmonary infection, pulmonary hypertension, respiratory failure. But in this case, specifically in case of bronchitis, you can say a few more. A, B, C, D. A for amyloidosis, very common, not so common, but very prominent, very remarkable long-term complication, amyloidosis. B for massive bleeding, B for bleeding, C for corpulmonal. That's it. A, B, C. Okay? A, B, C. Same is management. A for active breathing, active cycle breathing. B for bronchodilator. C for corticosteroid. Management. Finish. Okay, so far, so questions. Any questions from the Dr. Hanan first, then from others?
Just the investigation issue, should I say, I will start with lab investigation. Okay.
Yeah, I'm here. So investigations, okay, this is the, focus examinations followed by other system inquiry if you think of which is appropriate for it. I just randomly make some here, okay. So it could, during inspection, you can check about tachycardia, is the patient is tachypneic presence or not, look at the tracheal position, chest expansions, not palpation is always needed due to time pressure. Inverse lymph node is very important to check the neck first, okay, percussion not needed, just for sake of discussions I mentioned here. Very good investment of the time is required in case of auscultations, okay? Give some time, because if in the setting of lung cancer, there could be consolidations, collapse, and pleural effusions, right? So other system inquiry, when you, cover the major system, just look for other findings. Look at the anemia. The anemia is a complications of long-term blood loss, okay? If it is lung carcinoma, look for paraneoplasty. By the way, this slide I prepared for, in general, to cover the whole things, okay? Lung carcinoma, as well as also other things. So don't mess up with just with the bronchitis only. Hyperplasia can be present in case of racemic granulomatosis. Yeah, you can get the impression of the proptosis. Congestion might be present in case of superior vena cava obstructions due to small cell carcinoma. Abdomen ascites might be present due to heart failure as well as also MERS. Okay. Lymph node is very important. Non-pulsatile venous pulsation might be present. So head and nail, in the hand and nail, you can flap, get the flap. Proximal myopathy can be present. Can anyone say how? In a setting of lung carcinoma, how proximal myopathy can be present? Be interactive, come forward, make the paces peaceful. Anyone? In a setting of?
Into Lambert's paraneoplastic.
In a setting of lung carcinoma, patients usually may present with some paraneoplastic features, dermatomyositis. Yeah. Yes. Thank you. So think as a whole, not just be a, tunnel vision, okay, person. Okay, we have to make think broadly. Nail in the nicotine, yes, scar, you already asked that. Erythema, hand muscle wasting might be present due to Pancoast. Everything is a pedal edema plus minus, depend on the case. Next, this is the investigation panel. My calibration was bronchiectasis. Definitely differential will be carcinoma of the lung by default. Learn from today. In any case of bronchiectasis, the first differential by default, lung carcinoma, so far, until otherwise. TB is a differential, good differential. So you can fix it, encrypt it in your mind. Hopefully it will work. So palliative care, it depends on the scenario.
Sorry, doctor. The complaint is very short, like 6 days.
Yeah.
So how could it be cancer?
No. It was my pre-existing calibrations, okay? But I calibrated according to the bronchiectasis. I said that, but this was my case, not necessarily. This order is actually representing our role play. Did you get my point?
So in this case, which has been done now, the top differential is bronchiectasis.
Yeah,
am I right?
definitely, yes.
But also, I think bronchiectasis needs time. So 6 days is.
No, yeah, definitely. You raised a very good questions, but I gave a very good history. Patient has 6 weeks problems, pre-existing intermittent shortness of the breath, especially the history of TB, travel history 10 years back.
Okay.
Yeah. If you connect as a whole, you will not miss. If you just think just recent past or recent future, that will make you in a trap situation. Think as a whole, the patient has some travel, hospitalized, but you did not ask for which reason he was hospitalized. Okay. I'm going a little bit faster. Okay. So palliative care we can give in different situations, especially in the pancreas tumor case, dexamethasone radiotherapy, supravenous cable obstruction, you know that. Effusion, in case of effusion, chemical fluoridesis by talc, okay, tetracycline can be given. For the combat of cough and pain, opiate can be given in a cancer patient. What are the indication of radiotherapy? These are the commonly encountered question in the patients if you get the case of lung carcinoma. 3B, okay? Boring cough, bleeding cough, bone pain. Remember this. Then investigation, I already mentioned everything, okay?
So is bleeding cough?
Sorry?
Bleeding cough, do you mean hemoptysis?
Yeah, hemoptysis. I mean, for the sake of the mnemonics, I mentioned boring cough means intractable cough, always cough, okay? Bleeding cough, okay? And bone pain. These are the indication of the radiotherapy. I already mentioned all the investigations here, and management actually depends upon the cause, but in this case, bronchiectasis, you have to say just physiotherapy, pulmonary rehabilitation, vaccination is very key. If the case is cancer, in that case, you can say detect to the, it depends on the type of the cancer, but if it is small cell, or in that case, chemo and radio followed by surgery. If it is non-small, surgery the first, followed by chemo, radio, as well as palliative. Any questions so far?
Regarding the oxygen saturation, it was 92.
Yeah.
So Any concern about this?
Any concern? Yes, definitely we can ask. Okay, are you dependent on the oxygens or not? Yeah, okay, any shortness of the breath. That's why I put the 92. And you can do some ABG, although I did not. Yes, I did. I mentioned ABG. Okay, ABG, you can do ABG. You can do ABG.
Okay, and
Any question?
I'm going to admit that patient.
Definitely. Yeah, definitely. I'm going to admit. I will also teach in another sessions, okay, how to finish the, I mean, last 2 minutes. You should follow the admit approach. ADMIT. What I mean by that, A for admit. Look at the scenario. Is it emergency or not? Do you admission needed or not? If it is admission needed, you should mention I'm going to admit, or you not need to admit, just need to stay in the ambulatory care unit. D for AD. D for any drugs should be omitted or should be started immediately. If it is Raynaud's, patient probably on beta blocker, you should stop it. If it is multiple sclerosis, immediate starting of the IV steroid is very important. So D for drugs, and at the same time D for driving. If it involves the visions or any problems, you should stop the driving in the management plan. You need to stop the driving. I will mention later. M for involve multidisciplinary team and mention few management plan. Admit. I for involves his opinion according to the mark calibration and mark sheet. What do they think, which they prefer? T for finalize the treatments and also, I mean, thanks the patients at last. Okay, we are coming to, no thanks actually. T for actually treatment, further treatments. So these are the admit approach, okay? A for admission presence needed or not. D for any drugs need to be started or need to be omitted, or D for driving, address the driving. In case of some situation, dual is the term. ASOCM patient probably planning to make a family. I mean, dual, becoming single from dual from single. Okay, so you have when patient is planning to make a family, or dual, becoming dual in recently, in that case, family issue should be addressed. Aim for involving the multidisciplinary team, mention some investigation. Okay. I for give proper information and involve the patient, what treatment options they prefer. And lastly, give some treatment plan, and they will move forward with the appropriate investigation and let you know what's the update. Anything, any questions, any concern, any correction?
So yes, I have a question in the management.
Yeah, sure.
Should I start with the pharmacological and come later on to non-pharmacological?
Yeah.
I mean, yeah.
It depends how. From my real examination experience, I'm saying, when the crossing is started, if you can start very fluently, already answered 2 questions, okay, during your presentation and differential, you justified your differential, they're asking the management plan, go for that. But when you already took so much time, and probably the best examiner taking so much time asking few questions, why did you tell that, why this you tell, justify it, you already notice that your time is running out, but they are not asking you about the management plan. You immediately start with management with definite. Did you get my point, Doctor?
Yeah.
Yeah. So all about your tips and tricks, all about how you're thinking of the game, but because the game is not fair for all. To be honest, the game is not fair for all. You have to be vigilant. Okay, time is running out. If they ask management, I would say 1. If they seek more, then you have option. Fine. The next slide. Probably we did not get the chance to discuss second case because we don't want to hurry. We'll have more session, no problem. So what other scenario, okay, may come in the real exam along with hemoptysis? This is very important, right? So TB, we know that already. TB endemic area, young patient, chronic cough, low grade pain, night sweat. Okay, so patient present with TB. On examination, you will get some cachectic, fever, crepitations, maybe present amount of stakes will be positive. This is pulmonary tuberculosis, right? The second scenario, one of the very common scenario we already discussed. Massive hemoptysis with chronic cough. Yeah, for the sake of a little bit confusion, I did not give the chronic history, but I keep something high to make and stimulate the real exam pressure for you, all for you, because I could make the case easy. But to be honest, I want you to pass in the exam. That's my intention. Okay. So symptoms: lung volume, hemoptysis, worsening cough, productive cough. I already gave all history, all findings. Long-standing cough might be present, but some intermittent impatient may remain completely well. Completely well. But in this case, patient has long history of TB. In the meantime, was patient fine. This flare up and presented with some infections, exacerbations, now worsening bronchiectasis. Okay. So I already gave the clubbing history. Tacos is also there. Bronchial breath sound, I hide it. Okay, I did not give it. So this is bronchiectasis. The next, the final one. Scenario 3, hemoptysis in the heart disease patients. So heart question is very important. You asked that was very fine. So you can ask about especially leg swelling, any nighttime symptoms. Okay, it's very important to exclude the rheumatic heart disease presence or not, because sometimes patient presented with some pulmonary hypertension and patients may present with hemoptysis. But if a good questions can help you rule it out. If anyone say any one single question can help you, this is cardiac or this is respiratory. The amount of bleeding can be a good clue. In the hemoptysis in a heart patient, the amount is very small. Okay. On contrast, in the bronchiectasis, the amount will be massive. So every teeny things make significant difference. In the scenario 4, chronic hemoptysis in a systemic symptoms. What is the systemic disease? Oesogenous granulomatosis. So history of sinusitis, nasal ulcer, hematuria, no smoking history, and the history of hemoptysis is recurrent. Okay, in that case, very important to seek out. Patient may have some proptosis, some nodule, some rash, some bleeding spot, some ulcer-like problems in different parts of the wall, different parts of the body. Okay, so this is oesogenous granulomatosis. It's a disease of old man, usually after 40. Okay, so age gender is a very good factor and carry important information if you can correlate, because nothing in the paces is given for just game. No, age, gender always matter. If you look at the scenario and carefully think and critically think, paces is all about your long-term thinking habit, how you think the scenario, considering patient age, considering patient gender. Lastly, the last and final scenario, hemoptysis with pulmonary embolism. This is one of the common scenario in the paces. But in the embolism setting, patient will have some pain rather than shortness of the breath. Pain is more prominent than shortness of the breath. Yeah, definitely shortness of the breath will be there. Patient will have tachycardia, tachypnea, recent history of surgery, cancer, long haul flight, OCP. If the young case, and now I'm asking to you, open for all. In the young case, patient has pulmonary embolism. 2 histories must. Who will say? 2 history you want to take. Dr. Tasnim, Dr. Hanan, and as well as also Dr. Rashik or other doctor can interact with me.
Sorry, what is the question?
In a young patient, if you want to take history, focused history of pulmonary embolism, what 2 history you want to take?
If females, I will ask about pills.
Okay, fine. Good. Very good. Number 1. Number 2?
Recent delivery or surgery.
Heck, yeah, it could be, but more than any rash or any joint pain, SLE, or antiphospholipid syndrome.
Antiphospholipid.
Yeah. And definitely, I'm not disagreeing with you. Then surgery definitely come, but in elderly now, now the term in the elderly patients or aged patient, what 2 or 3 history will take. Anyone?
History of cancer.
Yes, good, very good. Number 2, surgery. Number 3,
Surgery. Yeah.
long haul flight in case of both male, female, young. Okay. So any questions so far? I know I'm counting. Okay, Dr. Tasnim probably did not practice today. Inshallah, in the upcoming days you will practice 2 cases, no problems. I'm counting everything. No. So, any questions so far from this scenario or any scenario from any session? Anything? I'm just stopping the recording. Any questions? Please feel free. Dr. Daj Bhaiya is there. Dr. Faisal Bhaiya, you can interact.
Are we going to have the recording in a Telegram group, or
Yeah.
how can we do it?
Okay, just hold a few seconds.
Good.